Hello and welcome to another episode of Onc Now. Last time out, we had a wonderful conversation with Professor Sarah Blagden. Please join me now for the second part. I hope you enjoy.
So you've been at the forefront of many significant projects and your work with the Oxford Cancer Clinical Trials Office and as the founder of RNA Guardian. So tell us about RNA Guardian, how it came about.
Yeah, the RNA, the name was because it was really describing RNA binding proteins, which are kind of guardians to RNA. I talked about them before. They can distort the message. They kind of cling to RNA and kind of boss it around, basically. And we know that we can actually detect some of those in the circulation. And it really came out of basically my failure to be able to get any grant funding to explore what it was doing in the circulation, why I could pick up this LOP1, this RNA binding protein in the circulation. I could find that it was present in cancer patients. And because it's unusual because we can also detect it in precancers. And I explained before that precancers, or this early gestational phase, it doesn't really express the same biomarkers as cancer, but there are some proteins that do cross over. So we started to look for it in circulation. And yes, I couldn't get funding. And in the end, I decided, okay, I'm just going to start a company and just raise investment. And that's what we've been doing ever since.
And how far along are you?
We've raised some significant investment. We are now looking at using the test in the lung cancer detection pathway. So, ... I'll let you know.
Well, we'll have to, watch this space. We'll have to talk more about that. And it's interesting in this country. There seems to be less resistance for physicians, clinicians, scientists, pure scientists, to start companies. Certainly in the United States, a lot of people do it, but there's, sort of an academic purity. A lot of institutions don't allow it. There's the Sunshine Act over there, which is an impediment, but let's talk all about it at another time. The protein, mammalian target, I have to read these.
mTOR.
Yeah, mTOR.
Well, don't worry.
Mammalian target of rapamycin, I had to look it up, being characterized as a master regulator of cellular homeostasis. And you've mentioned LARP1 targets is selectively binding to cancer-related mRNA transcripts. Can you elaborate on the significance of this and what it reveals about cancer biology, mTOR?
Well, mTOR is mTOR is very important because it basically tells cells when to divide and grow. So it has a very kind of anabolic effect. So if there's nutrient availability, if all is well, it comes on and it kind of gets the cells into sort of save mode, start storing and things like that. But when that nutrient availability is cut short or when the cell is stressed, then it turns off. And the cell then switches on AMPK and it goes into a kind of autophagy, kind of recycling mode. So it's really important helping the cell switch between the two. We know that it's often dysregulated in cancer. So about 80% of cancers have distorted levels of mTOR, usually very high levels of mTOR. So it's interesting. And there was the problem was that although mTOR was known to affect something called ribosome biogenesis, which is just basically making the manufacturing the proteins needed to create other proteins. So it was important for that, but it didn't really have any fingerprints actually on the process itself. So it was obviously acting for a middleman, and that middleman turned out to be LARP1, which was the protein and gene that I've been working on. But our sort of recent work has shown that actually LARP1 is also responding to quite a lot of other incoming signals. So it's kind of acting at a kind of central nexus. And I think that it's fascinating to me because it's over 2 billion years old, LARP1. So it's been around a long time. And yet it's been conserved in almost identical form all the way through evolution. So it implies that it's doing some very important role. And I think that what it is actually doing is it's kind of acting at the interface between sort of growth factor signaling, so the sort of hardwiring of the cell, telling the cell what to do, and this very ancient kind of metabolic signaling, which actually it has evolved from photosynthesis. It's a completely different kind of origin. And the two wouldn't normally get on, and I think that the RNA binding proteins are kind of sticking them together. So enabling one to communicate with the other, kind of like Velcroing them together in cell. So that's
fascinating. 2 billion. So it's been detected in the earliest
Absolutely, yeah. And it's important because one of the things that you hear about is people saying, oh, I'm going to starve my cancer of sugar. But what your cancer does is it immediately switches metabolism. So it makes its own sugar, or it uses something else as sugar, glutamine or something. And so actually that it doesn't work doing that because you have this metabolic plasticity in the cell. And that, I think, is sort of engineered through these connections, through these RNA binding proteins and through these downstream signaling cascades. So we're really just, at the moment, proteomics is really taking off at the moment. So we're really starting to understand what's going on in the cell, and it's a kind of really interesting time.
Absolutely. I think back to how our comprehension of cancer has changed from the ancient days when I went to medical school. I mean, they say that within 5 years, 50% of what you learn is proven to be correct. And the problem is knowing which 50%, if you stick around long enough, everything's in.
I know. Well, I think I'm know that for you already. Yeah. I know. I go on the ward because sometimes I do ward cover, and they're speaking. The juniors are speaking in acronyms, which I don't understand.
Yeah. Oh, I always hated those damn things. DOA, dead on arrival, or datum of admission.
I know. Well, they say something like the A540 score is elevated. I don't know what that means.
I sometimes think they're just winding us.
And well, they totally are. They totally are. And the times where you
the old consultants come and let's have some fun.
And you're pretending that, okay, that's how it's worry.
Got you. So we were talking earlier, public awareness and the ability to talk about things like breast cancer has changed. And there have been enormous advances in breast cancer detection and treatment. Same can be said about ovarian cancer. What hope is there for better earlier diagnosis? You've talked a lot about looking at early stages, in various internal organ diseases. What's status for ovarian?
Well, I think it is a kind of orphan cancer in many ways, as you say, because it's really overshadowed. Where in the recent past, we had the NCRI in place. We would have kind of tumor groups. And they would support research in, specific tumor types. And that was really important, especially the rarer tumor types. But that's now being dissolved. And so we're really relying on the charities to, push and fight and get their message out. And there are some ovarian cancer charities, and they have been doing a good job at that. But I feel it's unfair. The responsibility is now purely on them in order to make sure that research continues in that area and make sure that fundraising happens. So it is a problem. And I think ovarian cancer is another disease that actually takes a long time to develop. It takes about 4 to 7 years to develop. And it doesn't even start in the ovaries. The main type, high-grade serous, actually starts in the fallopian tubes. Mm. So, there's a move about surgeons, if they're going in and operating on a woman for another reason, to offer to resect their fallopian tubes just to protect them from ovarian cancer, which does seem a bit radical. But again, we need good biomarkers. We need to be able to start to have a better way of understanding when someone is at highest risk, and women are at highest risk in their early 60s, which is actually where most of the cancers peak.
Yes, yeah. Here's hoping. I recently spoke on another podcast, Dr. Azra Raza from New York, and she's written a book called The First Cell, which she's a very legitimate oncologist and cancer researcher, but she's had a very provocative view that our approach to cancer is wrong, and that we're approaching the disease far too far down the line, and we should be looking at the sort of things you're talking about. She's a delightful woman as well, who also reads poetry online, quite a character. So can you expand on that, how we need to perceive cancer differently, and what are the challenges in doing translational type research? You've already mentioned the amount of time it takes to do one of these studies. AI, using avatars of patients to comparative trials. What can we do to put what she talks about, what you've talked about, into action?
Yeah, I think, it actually also goes back to, I was enjoying reading Peter Attia's book called Outlive, and it's about this idea of medicine 1.0, 2.0, and 3.0, it sounds a little bit similar where, medieval medicine is 1.0. We're currently in 2.0, where we're very reactive. We're reactive. We respond to advanced disease with our therapies. But he was advocating for a shift to medicine 3.0, which is exactly what you're talking about, which is about having heightened awareness of your risks and starting to prevent, making lifestyle choices to prevent disease. Easier said than done, because we don't actually understand, again, going back to the biology, we don't really understand the biology of how normal cells transitioned to becoming cancer. And for a long time, there wasn't really much funding in that area because it's not really considered oncology, for example, because there's not cancer. So it's in, and it's not normal cells. It's not kind of normal medicine either. So it doesn't really isn't owned by a specialty. And I think it's kind of sat in this lacuna for a long time of kind of lack of knowledge. And I think in answer to your question, how do you really resolve that? I think it's massively collaborative. You're talking about AI, sharing platforms and sharing knowledge, and we're trying to do that actually in Oxford, is trying to sort of coalesce research around this and say, okay, right, I think what, we can see, we would like to start doing these studies, and we need to get there. We need to understand this XYZ and really commission scientists to come in and help us. And that's what we've been doing. So we're sort of working at, for example, developing vaccines against these very subtle neoantigens or little proteins that are expressed on the surface of precancers. And the idea being that you could do exactly what we talked about earlier, and that's sort of shift the precancer dial backwards to normal with the help of the vaccine.
I'm wondering how, when I've talked to other people about this politically correct expression, vaccine hesitancy, which it makes my teeth itch. But there are people who feel like, there's major conspiracies.
Yeah.
Doesn't matter what you tell them or what you show them, they are resistant. Sometimes very, very intelligent, very smart people. But, pseudoscience gets in the way of sentience. How are you going to have that conversation about a cancer vaccine? I think it was hard enough with a lot of people, with the HPV vaccine.
Yeah. I think it's interesting. I think part of the problem with COVID was that they didn't have time to sort of do all that preparation of the public, public engagement, the correct messaging. So it all got a bit distorted. And of course, you had to have it stamped virtually on your passport. Whereas I think a cancer vaccine is not going to be mandatory. So it's more likely that it is going to be, I think, first tested in people at high risk, who are actually desperate for something, anything, to prevent them dying as they watch their own family members die of cancer. And, if you talk to the Framini community, they say it's like waiting for the shoe to drop. It's this horrible, sword of Damocles, is putting it mildly. And actually, in the States, the advocacy groups who want cancer vaccines to be developed use this slogan, please just give us a shot, which is actually a really nice way of saying it. So it's almost the opposite of the anti-vaxxer thing. But I think you raise an important point, and I think it's about really identifying people who are at risk and really targeting prevention in that area. But there has to be a lot of public engagement before that. So we're doing quite a lot of work at the moment, having forums, and we've done a few sort of town board meetings, and advertised on Twitter to get people together and hearing their concerns. It's really interesting.
Very, very shrewd move. There's a chap I know in the States, I want to credit him. It's an Englishman. He lives actually in Canada, Vancouver. Dov Barron, if you're listening, Dov, kudos, man. He made the point that we have an emotion source code. We all do. He thought that the problem in the United States where acceptance of vaccination was lower, it was because people were being told to get vaccinated.
Yeah.
He said Americans don't do well with being told. Part of their emotional source code. The land of the free.
Yeah.
Right? Don't tell me what to do. Don't tread on me kind of philosophy. So I commend you for reaching out, trying to engage people in a dialogue. Then hopefully they view scientists and clinicians as they're being in their camp and not being another word you use, paternalistic.
Yeah, well, I did a bit of work thinking about vaccine acceptance in the ultra-Orthodox Jewish community. And so I spoke to rabbis and things and talked about, okay, if we could develop a vaccine that prevented BRCA-associated cancer, because they have a very high BRCA incidence, 1 in 40, which is much higher than in the general population, how acceptable would that be? And the message I got really loud and clear was, we don't want to be told what to do. We want to be able to have a philosophical discussion. That is, we need to think far ahead of what the implications of this are. And unless you're prepared to engage in those kind of conversations, we're not prepared to take part, which I thought was really interesting. And it goes back to your point. I think there needs to be a different style of communication than doctors perhaps had originally, particularly if we're going into this group where we're not treating patients, we're treating people.
Yeah. They're not patients.
They're not paid.
Hopefully they won't become.
They don't want to be paid. Yeah.
So I was at Anglia Ruskin the other day having a conversation with a group about various things, and one of the other speakers made a really interesting point. He was advising medical students about, here's what your career could look like. You could be a clinician, and he listed all the pros, and it was, all the benefits. It was quite funny. He said, you'll probably earn more money and you'll probably get bored more quickly, or you can be an academic, maybe with some clinical involvement. You will not be as wealthy, but you'll be intellectually stimulated and you're much less likely to retire early. So you've experienced both, right? And you're working in a cutting edge area. What advice would you give to a medical student right now about, would you be encouraging them to follow in your footsteps and go, hey, this is a great way to spend your life?
I do that. I think my career it hasn't been a very standard path. I've kind of, as you pointed out, I've done a bit of research on fruit flies. I've then come back and then gone back to the clinic and then started a lab. And then I've kind of drifted into clinical trials and now I've gone into prevention. I think for me, I've always been very inclined to just follow when the doors open ahead of me, I just go through them. I don't kind of force a plan on my career. I just kind of go with the flow. And so that would be my advice. I wouldn't necessarily follow anybody else's career. Really just let your career tell you what to do, and just have faith in that, because you're here now. I mean, that wouldn't be something you'd expect to.
Oh, good Lord, no. And in fact, that's what I said pretty much the same thing, that, just be open to possibilities.
Yeah.
And, in the United States, they have this thing, the town gown.
Yeah, they have that in Oxford, yeah.
You're either in private practice or you're an academic, yeah, of course. And there's one of my colleagues from Los Angeles who, Leo, if you're listening, bless you, one of the funniest people I've ever met, a superb surgeon, but he was always, digging at the, the full-time staff, full-time faculty, and those who had an academic pursuit. And I said to him, I'm actually going to pay you a compliment that you're going to see as an insult. I think you're an academic. And he said, what do you mean by that? I said, well, you question everything. You don't accept anything. You have a fertile imagination and you test things. That's academics. You don't have to be, you do very clever stuff with Drosophila and now with other things. But being an academic just means that you question. I think that you stay mentally alert.
Yeah, I think medicine does teach you some important things, though, because it teaches you pattern recognition. You start to recognize symptoms and you put them together and make a diagnosis. And when you transition that to science, it's actually quite helpful. Yes. And I also think that, medicine teaches you to sort of not ask so much how, but more why. What's the bigger picture? Why does that happen? And I think both of those things are really important assets to have in your research, to keep stepping back and thinking, but why is this happening? Yeah, but why is this happening? And to recognize, okay, that's happened there, but that's not a typical thing for cancer to do. And, you've got some instinct about that.
Yeah. Well, sadly, we're running out of time, but I always like to ask people that if they came across a magic genie were granted 3 wishes for your area of healthcare, frankly, what would they be?
3 wishes. Well, I think that my 3 wishes in the future would be that I would like cancer to be predictable, preventable, and as a result, unusual.
Like it. You need another P and then you'll...
I know, it's another word for predictable, preventable, and kind of avoidable, or kind of sort of unexpected, when it actually happens. So you have many fewer cases of cancer in the future. That's what I'd really like to see.
Well, one thing is for sure, and that's you're going to play a role in increasing our knowledge about that. I'd really like to thank you for coming in today, Sarah, and for educating me for sure, and for everything you're doing for the science of patients who are living with malignancy or facing it.
Well, thank you very much for having me. I've really enjoyed myself.
So, folks, thanks for listening to this episode of Onc Now. If you've enjoyed listening, and I suppose if you're watching this, you must have, please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts so that you never miss an episode. And check out the archives. There's going to be lots of great episodes there. Until next time, I'm Jonathan Sakia. I thank you for listening. Please, everyone, stay safe, stay well, stay curious. Bye for now.